Okay. Am I audible now?
Yes, sir. Now you're perfect.
Okay.
Good, sir. Good, sir.
Okay, we'll start now. So good evening to all of you. As usual, I will start with a short case first. No, not a short case. No, this is, last class I promised that I will tell you about something about the types of facial sensory loss in lateral syndrome and how the sensory ataxia can be so severe, and some case examples and the diagnosing thoracic outlet syndrome. Those points I will clarify. Then I will go to the case. Now, let us first come to the various types of sensory loss in the elementary part. For that, you must know the descending tract of trigeminal nerve, how the pain fibers from the face is going. This tract actually closely accompanies the spinal nucleus here. This is spinal nucleus, which is descending down after the C4 of the spinal cord. And the tract, the pain fibers from here descend down in the nucleus at various levels. Here, one in here, another one in here, like that it descends. The fibers which end at the topmost are the fibers which come from the lower part of the face or in and around the mouth. The fibers which descend most down are the one coming from the upper part of the face. So fibers in the face and the nucleus at various levels up to the upper cervical cord and cross at various levels to form the ascending endothalamic tract. From each level it goes to the opposite side and tract called the ascending endothalamic tract. So I'll show it here diagrammatically here. This is the chief sensory nucleus. We're not interested in that. It's concerned with the painless fibers. The pain fibers on the face can divide into three laminations, one in and around the face. Then, at most outer is the one which is shown on the right. The fibers in the outermost part of the face, that is towards the periphery of the face, they descend most down and in the caudal part of the spinal nucleus. Those in the middle part and in the middle part of the spinal nucleus, and those from the area in and around the face, in and around the tip of the nose and lips, and in the upper part of the nucleus. For each level, this forms a descending tract, and the other one is a descending nucleus. At each level, it goes to the opposite side and form a tract called the ascending endothalamic tract. So this tract is the one which goes to the ventro-posterior nucleus of thalamus and then go to the thyroid cortex. So in fact, if you a lesion here in the ascending endothalamic tract or lesion in the descending tract or the descending nucleus, all can cause pain loss on one side of the face. So the right side is affected or left side is affected, you can pain loss. So hence one can get loss of pain in the ipsilateral face, contralateral face or both with the lesion confined to one side of the body. This loss may be restricted to one part of the face or the whole face depending upon which part of the tract is affected. Suppose this patient has got loss of pain one side of the face as shown here. How to know whether the lesion is in the ipsilateral descending tract of trigeminal nerve or in the ascending endothalamic tract or the contralateral side? What will you how to differentiate the two? What test will you differentiate the two? Corneal reflex. So if it is the descending tract, the corneal reflex is also lost on the same side. Whereas corneal reflex will not be affected if the lesion is in the endothalamic tract. Because the corneal reflex pathway, it comes down and into the spinal nucleus, but does not ascend through the ascending endothalamic tract. They go through another pathway to the submental nucleus. Well, this is the onion peel lamination. Suppose the lesion is there in the lowermost part of the spinal cord. It's affecting bilaterally. The area affected will be the most peripheral part be affected first. As the lesion goes up, as in case of syringobulbia going ascending up, the pain fibers gradually goes towards the nose. And the last part affected will be in and around the lips and mouth. So this is called the classical onion peel lamination. There is another type of lamination in which the uppermost part of the face descends down and into the caudal part of the spinal nucleus. The middle part of the nucleus, and the lower part in the upper part of the nucleus. So a particular patient can have either the non-NP lamination or an upside down lamination as shown here, or a combination of both. So if you want to suspect a caudal medulla or an upper cervical cord lesion, the first area to be affected is the part towards the periphery. This is the area you have to look for first, rather than the middle part. And that area will be affected the first in the case of a caudal medulla or lower spinal cord. That's the area you have to look for the loss of pain sensation. And the loss of an area of pain loss may be restricted to one area alone. For example, let us say one of the commonest symptoms of vertebral-based ischemia is circummoral paresthesia, which you all had read about in the textbook. How it is produced, let us find out. So look at this pathway. This is from the lower part of the face and then around the face and the upper part of the nucleus here. This crosses to the opposite side like that. Similarly, that forms a quintothalamic tract. The middle part little lower down and upper part little lower down. The same thing is also coming from the contralateral side. Okay. Suppose there is a lesion in the fiber in and around this area where the fibers in the lower part alone is affected. What will happen? See, that area is affected. What will happen? Only the area in and around the mouth will be affected first. So it is what we call a circummoral paresthesia. So in a lesion, this can occur only if the lesion is in the submiddle part of the pons, where the fibers crossing from the lower part of the face or middle part of the face is crossing and ascending. Okay, so that is pathophysiology of the circummoral paresthesia. If somebody complains of paresthesia like that, initially always think of intrinsic intramedullary lesion or intraaxial lesion in the brainstem. Now come to the facial patterns of sensory loss in Trigeminal syndrome. Now this is the classical type which you see. Here before going to the pattern, let us see the anatomy of the medulla. This is the cross-section of the medulla, is inferior nucleus, this is inferior epidangle. What we are interested is these three tracts. This is the descending tract of trigeminal nerve nucleus. This is the ascending quintothalamic tract which carries pain fibers on the opposite side. And this is the spinothalamic tract, which carries pain from the contralateral side of the body. There is a lamination here, just like in the spinal cord. The sacral area is lateral most, then come the leg, then come the head, and middle most is the arm. So if you have got any doubt in between, please stop me. You can interrupt and ask me clarify and then go on. So this is the area in the lateral medulla. This ascending quintothalamic tract is situated more medially than the descending tract. Descending tract is lateral. This fibers crossing here goes medially and ascending. In the classical pattern, this is the area of the infarct. Lateral, the one which is circled and shown in the gray color is the area of infarct in all my diagrams. So here it is affecting the descending tract of trigeminal nerve as well as the whole of the spinothalamic tract. So what we classically get, the ipsilateral loss of facial sensation, loss of corneal impulse on that side, and the pain loss on the entire contralateral side of the body. That is the classical type. It's all described in the textbook. The patterns can be quite variable depending upon which part is affected. Let us see one by one. This is another common pattern which I just seen, which is called stopwatch type 1. These patterns are named by the stopwatch as type 1, 2, 3, and 4, like that. I'll show each pattern. There's nothing to remember, but only the location where it is affected, you get the, the anatomy, you get the deficit. Suppose the infarct is located in the lateral part, far lateral part here. It is affecting the descending tract of trigeminal nerve and the lateral part of the spinothalamic tract. In the lateral part, as you know, the lamination is it carries pain fibers from the contralateral lower limb. So what you're going to get now that is affected, you get lateral loss of pain and temperature loss on the face and contralateral loss of pain and temperature loss on the opposite lower limb and lower trunk. It spares upper limb. So that is called the stopwatch type 1 or the far lateral medullary infarction. Now let's see the middle part is affected. Instead of the lateral part, this part happens to be affected, which involves the ascending endothalamic tract, which carries the pain from the contractile phase, and the medial part of the parathalamic tract, which carries the pain and temperature from the contractile limb. Then what will you get? You get loss of pain and temperature on the right side of the face, contractile phase, and portal limb. This is called the mediolateral medullary syndrome or the Stockport type 2. Suppose the entire part is affected, you get the ciliary nucleus affected, endothalamic tract affected, endothalamic tract affected, you get a picture like this. So you get loss of pain both sides of the face and frontal side of the body. So in that case, one mistake we always do, we compare the pain loss from one side to the other. It should not be. You should always compare the pain loss on one side of the face with the ipsilateral occipital area or ipsilateral body. Because don't compare with the opposite face, because that face also may be affected. Suppose if both sides are affected, the patient will not see any difference between the two. So always compare with the ipsilateral occiput or the ipsilateral of the body. Then only you can find out that face is affected or not. That part of the face is affected or not. Because this area will not be affected. So always compare this area with the ipsilateral body. Should not be comparing with both sides of the face, because both may be affected as in this situation. This is the dorsolateral medullary infarct, otherwise called the Stockport type 3, which is nothing but the combination of top 1 and 2. Then imagine that the lesion is here. It is involved in the ascending endothalamic tract, endothalamic tract, space the descending tract. You get a picture like this. The entire right side of the body and face is affected. So what does it mimic? It mimics like a thalamic infarct, because it's always, entire thing is on the opposite side. So naturally, one have tended to think of thalamic infarct. But remember, this can also occur with a lesion like this. But it is in the thalamic tract and the last thalamic tract. Suppose it so happens that lesion happens only to affect the descending nucleus, only get loss of pain with that nucleus. So it may mimic that of a trigeminal nerve involvement. But here, touch will be spared in the case of medullary lesion, whereas in trigeminal nerve involvement, touch will be. Then, if you think only parathalamic tract affected, you get entire space will be spared, only body will be affected. Again, what will you consider? It may suspect you may erroneously suspect that the patient has got a spinal cord involvement. So this is another type where the descending tract is spared, ascending endothalamic tract is spared. Suppose only the lateralmost part of parathalamic tract affected, you can have pain loss only on the contralateral side of the right lower limb. So what will you may get a level in the contralateral lower limb up to the mid trunk. You may erroneously diagnose a thoracic condition. You take an MRI, somebody comes. Previously had a patient who come with that. When she was taking bath, she noticed that she could not feel the warmth of the hot water on the right lower limb. That's only complaint. Examined the referring doctor took an MRI of the cervical spine, and nothing it could be found. I also initially thought that it could be cord lesion. But subsequent examination, they found that the MRI was normal, and when they checked that he had a Horner syndrome on the opposite side. And that was the only clue to suspect that patient's got lateral brain infarct. So repeat MRI brain showed a lateral brain infarct. So this kind of a pattern can sometimes occur with a lateral brain infarct. So this is regarding the this type of sensory loss in lateral brain infarct. So before I go to the next case, any doubts in this diagram?
Sir, why to check the occipital, sir? I have seen you checking the occipital. Why to check that one?
Occipital or the ipsilateral body, anywhere is possible. But it is better to, because the pain sensitivity is easy to check from here into the occipital than to the body. That's all. You can check anywhere, left occiput or left side of the body.
No, sir. The reason for checking, why should we check to differentiate from which lesion?
I'll tell you, because suppose in the Stockport type 3, you see what is happening here now. Both sides are affected. Okay, so if you compare the both sides of the face, both will be affected. You may think that the facial sensations are normal, or one side may be affected more than the other. You may think that the affected area, the one which is affected is only affected area. but the other part of the face may also be involved because they like this. So in that case, to compare that, you have to compare with the normal area. The normal area is the ipsilateral body, not the contralateral body, not the contralateral face. You understood? But both faces may be affected. So you can compare only with this area, no? Left side of the trunk, left occiput or the body. Occiput also is coming under the body because the C2 is the one supplying that.
Yes, sir. Thank you.
Any other doubts? Okay, I'll go to a case. I'll show the case. Why I'm showing this case, I'll tell you later on, because this is answering the one question which was asked to me last week. The 65-year-old man noticed weakness and wasting in the left hand following CABG 3 months back. The weakness partially improved, but mild weakness is persisting. Also noticed numbness of his little finger. This is the video of the patient. Deltoid normal, biceps normal, triceps normal. There is mild wasting of the small muscles of the hand on the left side. Finger flexors were normal. Look very carefully. Finger flexors is normal in the right side, but mild weakness on the left side. I can overcome. The long finger flexors were weak, mildly weak. I could overcome. To the right side, I could not do that. Flexor is longest is normal on the right side, weak on the left side, mildly weak on the left side. I could overcome that. Digitorum is normal on the right side, slightly weak on the left side. I can overcome that. So the left hand. That's good power. The small muscles that is normal on the right side, slightly is also weak, is weak on the left side. That is normal, that's weak. Abductor pollicis brevis, normal on the right side. It's also mildly weak, but not very good power compared to other muscles, but still weak. Neurology with normal on the right side, weak on the left side. Common sign was negative. Did not make an O. That is not possible. Like that, there is weakness of the pollicis longus and longus. The plexus biceps supinated normal. Right, it's sluggish on the left side. Even the triceps was normal. It was slightly less. Right side as well elicited. That is equal. It's a little less on that side. That is equal. Ring finger, little finger was less. It's left normal, but decrease on the little finger. Normal. This area where the sensory loss is there. The finger in the middle part of the palm. So the examination, weakness of the following muscles were noticed. Left flexor digitorum longus and superficialis, flexor pollicis longus. Weakness of left APB, mild weakness, left dorsal palmar cruciate, left hypothenar muscles. O sign was positive. Pollicis O was normal. Normal triceps, normal wrist extensions, normal finger extensions. DTR, left triceps stiffness is decreased compared to the right. Decreased sensation for the left little finger and medial palm. This is area of sensory loss, which is shown by the area. So where is a localization?
CAT1 radiculopathy is the first one, sir.
Okay, CAD1 radiculopathy, good, very good. Probably C7 also because the triceps is less, but as you said correctly, may C7 may not be affected, CAD1 radiculopathy. Any other thoughts?
Same thing, sir, but the CH seems to be more affected. CH.
CAD, okay, CAD is more. Okay. Could it be a plexus involvement?
Yes, sir. Lower trunk, sir. Lower trunk.
Lower trunk. Your triceps is affected partly, middle trunk also is getting involved. Okay, that's possible.
Yes, sir.
Sensory.
Pardon? There is no harness. No harness. No harness. Okay, what do you want me to do? C7, C8 radiculopathy, predominantly C8. C7 is noted because CAD1 also, middle and lower. These are the two possibilities. Okay. Because the triceps repress is decreased. Otherwise, there is no other evidence of C7 rooted. Now, what test you need?
Nerve conduction MRI.
Okay, let's say nerve conduction. Left median, normal amplitude, thenar muscle. Right median, of course, is normal. Left ulnar, low amplitude, 3.3. Right ulnar, 8.8 millimeter. Okay. Now, radial, normal, both right and left. Muscular cutaneous, normal. Then, FA study is normal. Sensory, normal, ulnar nerve, under distribution, median normal. Radial normal. Medial antebrachial cutaneous nerve, lateral antebrachial cutaneous nerve, normal belly. So, once again, tell you the abnormality was that is CMAP was decreased in the ulnar nerve with the ADM, and SNAP was decreased in the ulnar nerve distribution. But the thenar muscle from the APB was normal, amplitude was normal. Something like ulnar nerve distribution. So, what is the diagnosis now?
Still, it is C8, T1 also. Predominantly C8. There's a sensory. What about the CMAP from the ulnar, sir? And the left ulnar, is it reduced?
Yeah. CMAP is reduced.
Okay, there is yeah.
It's 3.3. The other was 15. Median was 15.8.
Okay. Because the middle antebrachial those are normal. So this could be predominantly C8 and mild T1 affection on the side, sir.
SNAP is involved.
Pardon?
SNAP amplitudes are low. In radiculopathy, you get normal SNAP amplitude.
Yeah, that's the thing. So it's a radiculopathy because the SNAP is affected. Banana SNAP is affected. It cannot be root involved. It has to be distal to the root after coming from the spinal canal.
Okay.
So where should be the affection?
Lower trunk.
Sir, APB is affected clinically, no, sir?
Affected clinically, but the problem is that he's got other muscles also weak. So some degree of the difficulty can occur due to the fixation problem. So mild degree weakness may not be really there, even though I could overcome that. Even examination, only subtle difference is there on the opposite side. But electrophysiologically, APB is not affected. It's got good amplitude.
But then the finger flexors, sir, were there difference between the median and the ulnar clinically?
Yeah, no, there's no difference. All the finger flexors are affected.
Lower trunk.
Okay, lower trunk is a good possibility, right? Agreed with the possibility. But the problem what is in which lower trunk means which segment is if it's a lower trunk, why the median snap is normal?
Because
Yes.
it is outside the DRG.
Pardon? Yeah, of
Because
course. It's outside obviously, it's outside the dorsal root ganglion.
So the median sensory is coming from the upper trunk through the lateral body.
Well, not median sensory is not affected. I am talking about the medial motor. CMAP in the median nerve is normal.
Similar to the cervical rib, where the median motor.
So it is in
In the case
more
of
of C8 is involved.
correct.
More of
That's
C8 is involved.
That's answer. See, if you think of the thoracic outlet syndrome, the last class I told you, the first muscle affected is the APB. D1 root is affected. Okay.
Yes.
If the C8 root is C8 root means here the plexus, the lower trunk, the C8 component is affected, not the root. After exiting from the ganglion, that C8 segment is affected, portion is affected, and the APB can be spared. And you get the point. That is, the lesion is not in the root per se, it is in the root of the brachial plexus. That is, what is the root of the brachial plexus? In fact, there is always a confusion between the root and the radical and the thing. When we say root, usually we mean lesion proximal to the ganglion. But unfortunately, the root of the brachial plexus is also called as root. In fact, that root is formed by the anterior primary rami after both are joined together. The root of brachial plexus is formed by the ventral primary rami of the C5 to D1. But unfortunately, that is also called the root. The snap can be absent after the ganglion, anywhere after the ganglion. Are you following what I am trying to say?
Yes, sir.
Yeah.
But how to, sir, how to explain the mild weakness of the APB in this case, sir?
And somebody was asking, that's also what you said is correct. APB mild weakness, what I'm telling is that it may not be there really. Because all the other small muscles are also affected. Some degree of long finger flexors are also weak. Long is also weak. So some degree of apparent weakness can occur due to the other muscle weakness.
Sir, supposing there is a Martin-Gruber anastomosis, is it possible to have this sort of partial
No.
affection?
No, it will not be. It can't have that thing. Gruber anastomosis differences between proximal and distal stimulation. It's not like that. Wherever the stimulated is there, the amplitude is low.
In this patient, clinically, we'll have to say distal to medial cutaneous now the arm and forearm, no? If you go by clinical.
No, see, you can say like that, but the problem is distal means it comes to the ulnar nerve distribution or medial cord distal to that thing before erasing. That's what you're trying to say.
Yeah.
Correct. Even then, you expect thenar muscle to be affected.
Yeah. So in this patient, clinically and electrophysiologically, we'll have to say it's distal to the because they are not affected on clinically and electro.
You already said is correct, but in that case, if the medial cord is affected, distal to the medial and brachial cutaneous nerve, the medial root of the median is affected. Right?
Yeah.
If that is affected, thenar muscle should be affected.
Yeah, that cord affection also can involve the median nerve, no?
Yeah, but here the median nerve distribution is that the thenar muscle, abductor pollicis brevis is normal. The CMAP is normal. That's the top part.
അല്ല ഡിസ്റ്റലായ എന്താ പ്രശ്നം the electrophysiology
Like if electrophysiologically, this can explain only by ulnar nerve involvement. Ulnar nerve involvement I can explain. It mimics like ulnar nerve involvement. Steam decrease, snap is affected. But clinically, it is not ulnar nerve. Yeah. Okay.
അല്ല മറ്റേ കോഡ് ആണെങ്കിൽ the medial cord only supplies the small muscles of the median nerve അതന്നെയല്ലേ സപ്ലൈ ചെയ്യുന്നത്.
It is not supply the but unfortunately the thenar muscle is the abdominal brevis is normal. CMAP amplitude is normal.
You said the flexor ditorum profundus is weak.
Weak. That's also weak. They're all supplied by the medial cord. Agreed.
Yeah.
That means that it is not in the ulnar nerve.
That means it's a medial cord. What I mean is medial.
That means lesion has to be in the medial cord or above. Medial cord or above that. So this can occur as you can see each segment of that lower trunk is affected. I'll come to that. Okay. So this is the possibility. So what we are excluding is the root involvement. Middle and lower trunk, predominantly lower trunk. So what the patient had was, I told you one history I had given you, that is he has got a CABG. Now let us see the supply of this supply. The C8 is supplying this muscle. Normally all are supplied by the C8. D1 also contributes, but it didn't predominantly contribute to the APB as told last time. The APB is not coming here in this C8. And this is the area of the sensory loss. That's all you know about. They read about this point. They made the sternocleidomastoid brachial plexus with a complication resulting from rib cage retraction during open heart surgery. Also affects the lower trunk, but there is a predominant C8 involvement. This is more severe sensory axon loss in the ulnar nerve, hardly involvement of the D1 innervated structures. This is from the literature. Severe axon loss in the ulnar nerve distribution, hardly involvement of the D1 innervated. This is explanation. This is what is happening during middle sternotomy brachial plexus. So there is a fracture. During sternotomy, the first rib get disengaged from the vertebra, and that's exactly the site where the C8 root is coming. Means up there, the ganglion is coming outside the spinal cord is back. So that get affected predominantly. Now let us see. This is the D1 root. Okay. On the contrary, if there is a lesion compression here, the D1 will be affected first. That is in the next picture. The neurogenic thoracic outlet syndrome of the lower trunk of the brachial plexus. Lower trunk is found with the nerve roots of the C8 D1, but this one, the D1 root innervated structures is clinically much more evident. Electrophysiologically, the most severe axon loss is seen in the supply of the abductor pollicis brevis and the medial antebrachial cutaneous nerve. In most cases, thoracic outlet syndrome C8 structures are affected to much less degree. This is how the C8, see, this is the ligament of the thoracic outlet syndrome, which connected with the first rib. See, it is the part which is compressed is the D1 portion of the lower trunk. See, T1 portion is the one compressed. That is where the T1 get affected first. Severe part, other also can see it also get affected. But here, this is disrupted from here. That is when C8 is affected in median sternotomy. So this is actually last time I showed a case when the lady had only APB weakness. Remember that patient? She had a C7 transversomegaly, thoracic outlet syndrome due to enlarged and prolonged transverse vertebra. Transverse of the C7 vertebra. That patient only APB weakness. Electrophysiologically also only APB weakness. No sensory also on that patient. That is a D1 root. Here, the patient has got all muscle supply in the C8 is affected, but APB is spared, almost spared. Involvement is C8. So this is the pattern you get in the difference in the pattern you get between the post-thoracotomy of brachial plexus versus thoracic outlet syndrome. Okay. This I think I'll skip this. How this is produced, I'm just telling. Okay. Any questions?
Sir, what is the chance of getting a honors in this case, sir?
Honors is unlikely because honors fibers are coming mainly through the D1 and D2 route. So D1 is the one should be affected to produce honors.
Okay.
Syndrome, yes. C8 radiculopathy, not.
Okay.
Shall I go to the next case?
Yes, sir.
Okay. Now, a 60-year-old female is admitted with history of loosening of its apples without awareness for the last 4 months. Progressive difficulty in walking in the form of uneasiness, incontinence of urine for the last 3 months. A 60-year-old female admitted with history of loosening of its apples without awareness for the last 4 months. Progressive difficulty in walking in the form of uneasiness, incontinence of urine for the last 3 months. And she's now bedridden for the last 3 weeks. So totally in 4 months she became bedridden. No history of sensory complaints or sphincter problems. This is the patient. Power is normal in the upper limb.
Sphincter problem ഉണ്ടെന്നല്ലേ പറഞ്ഞു. You said this
There is sphincter problem. Incontinence.
incontinence of urine. No?
Yeah, incontinence of urine. Power is normal in the upper limb. No incontinence in the upper limb. Well, incontinence is the nose is striking the nose. Incontinence in the upper limb.
இப்படி ஒஸ்தி பிடிங்க இப்படி அப்படியே பிடிச்சிருங்க இப்படி பிடிங்கம்மா இப்படியே பிடிச்சிருங்க இப்படியே பிடிச்சிருங்க
Like that with eyes closed.
இப்படி இருக்கட்டும் இனி கண்ணு மூடட்டும்.
But closing the hand stops down.
இந்த காலை வச்சுங்கம்மா நல்லா குட்டி பிடிக்கணும். ஓகே ஓகே.
Power is normal, only but apparent disturbance weakness which may not be real. It is not her position of your limb.
பிடிங்கம்மா குட்டி பிடிங்க பிடிங்கம்மா பார்த்துட்டு விரல பார்த்துட்டே இருக்கணும் பார்த்து பிடிக்கணும். பார்த்துட்டே
Hold it up.
காலில் பார்த்துட்டே பிடிங்க இன்னும் பிடிங்க. ஓகே சவுட்டுங்கம்மா சவுட்டுங்க சவுட்டுங்க கீழே சவுட்டுங்கம்மா அப்படியே இல்லை கீழே இப்படி சவுட்டிகிட்டே இருங்க சவுட்டிட்டே. ജനറലി ഒരു ഗേറ്റ് 4 ഉണ്ട് ലൂസാക്കി കൊടുക്കമ്മ.
Normally LCD was slightly brisk, both upper and lower.
லூசா போடுங்க. ஐயா ஃப்ரீயா இப்படி அப்படியே வச்சுங்க.
Brisk upper and lower limb.
മുട്ട് മറച്ചിഞ്ചമ്മ രണ്ട് കാര്യം அப்படி அப்படி இருக்கட்டும் அப்படி இருக்கட்டும் அவ்வளோ வேண்டாம் அப்படி இருக்காங்க. பலம் கொடுக்காதீங்க இருக்காதுன்னு எழுதிங்கம்மா லூஸாக போடுங்க. காலை வச்சுக்க வலிக்காதீங்கம்மா அம்மா காலை நீங்கள் அப்படியே போட்டுட்டா போதும் வலிக்காதீங்க.
It does not have very limpy. There is a big problem. And there is mute.
அம்மா கை காட்டுங்கம்மா. இப்ப தெரியுதா கிருக்கிறான்னு?
Not be able to feel the vibration in the hand.
இப்ப
Is able to be little bit on this thing, on the wrist.
இப்ப இல்ல இப்ப
The wrist is able to feel little bit. Not absent in the lower limb. Absent in the iliac crest.
இல்லான்னு என்னோட சொல்ல இல்ல இருக்குன்னா சொல்ல இல்லாட்ட இல்ல.
Not able to feel in the iliac crest.
இப்ப
Look at the sternum.
ഇപ്പം
She is able to feel for the sternum.
ഒന്നുമില്ല. இந்த விரல கீழே முள்ளான்னு சொல்லணும்.
Now in present sense, totally she is not able to appreciate any movement.
தெரியுது. முள்ள இப்ப அனக்கன்னு தெரியல. அனக்கன்னு அனக்கு இல்லையா?
She does not even feel the movement.
ஒன்னோட எந்திரிச்சு
Look at the stance and gait. Even while sitting, her tongue wobbles.
அப்படி இருங்க. கை இப்படி நீட்டி வைங்க. அப்படி இருக்கணும். வேற காத்தி இருக்கணும். கலந்து இருக்கணும். கண்ணு மூடுங்கம்மா.
See what is happening in the trunk. On closing, the trunk goes backward.
When the trunk is swaying, that means severe postpartum control even the trunk also.
It cannot make a step walking. It's severe steadiness in walking. It needs 2% support to walk.
நான் நிக்க கவலைப்படாதீங்க. நேர பாருங்கம்மா. நேர பாருங்க. சாராம நில்லுங்க. நீ கண்ணு மூடுங்கம்மா.
I have to support her feet with it.
சாராம நில்லுங்க. நேர பார்த்து கண்ணு மூடுங்க. போதும். கால் முன்ன நடந்து காட்டுங்கம்மா.
See the foot, how it does it go?
நடந்து காட்டுங்க. நடந்து காட்டுங்க. நடந்து காட்டுங்கம்மா. உட்காருங்க. காலாத்தி உட்காருங்க.
Severe ataxia. So on examination, illness normal, motor power upper limbs normal, lower and right foot or the dorsal of the feet. Detail all brisk, plantar indefinite. Immediate vibration on both hands and in the lower limbs in some bit up to the including the iliac crest. Gait severe ataxia. Very localization.
Ankle reflex absence, sir.
Brisk.
So myelopathy involved in the posterior column. Probably survival.
Yeah. So the thing is that you can see how severe the ataxia is. Even upper limb incoordination is there in this patient. So the ataxia, sensory ataxia can be so severe, even to produce total inability to walk. Because this question was asked in Joy was asking, can body such as liver ataxia? Yes. Even tongue ataxia can also occur. She's not able, when closing the tongue goes backward. So, what do you want to dietary history? She's non-vegetarian.
Sir, there is a peripheral neuropathy as well as, apart from the dorsal column, the reflex are brisk. So, is it due to subclinical pyramidal involvement, sir?
Yeah, what is even say pyramidal involvement? I think pyramidal involvement is there because reflex are brisk.
Yeah.
Pyramidal tract is involved, not peripheral neuropathy. There is no evidence of any peripheral neuropathy.
But the angle check is lost, sir.
No, brisk. Angle check is brisk.
Okay. Sorry, sir. All right. Okay, sir.
Bladder involvement is very prominent. It's unusual.
Yeah, bladder involvement is there.
The touch is lost. Any sensory level? No.
No sensory level. In a sensory level for posterior column, the vibration is lost up to, see, the lower rib cage, it is lost. The
Pain and temperature? No. No
pain and
sensory
temperature
level.
is now. Pain, touch, pain, temperature.
Sir, how's the vision and the fundus?
Vision normal.
Hearing?
Their paleness are all normal. Hearing normal, paleness normal.
Because this much ataxia, we had cases in Kottayam, sir. With you, there is many cases of tropical ataxic
Neuropathy, correct. Right. But here is not an ataxic neuropathy. Yes, no neuropathy.
The reason for bladder symptoms is again posterior column.
Bladder symptom cannot occur with posterior column, can occur with my pyramidal tract involvement. And the main non-compressive myelopathy can also have bladder. It's not it. All can be.
Non-compressive myelopathy, posterior column and bladder.
Yes. What is diagnosis?
B12, sir.
Okay, B12 is a possibility. Okay, let us see. She's not in.
Sir,
There any
was there
open
any
surgery?
history of zinc or some dental
No.
paste or something?
No history of any drug intoxicant thing.
Any surgery, sir? He said anesthesia, general anesthesia.
No history of surgery.
STLV, proper.
Single tablet.
No single intoxication, not toxicity.
So some metallic toxicity because of Ayurvedic medication.
That usually produces neuropathy. And producing myelopathy is clear. Things like can produce myelopathy. Single intoxication and produce secondary to copper deficiency. But not, I don't know, the other things, produce neuropathy is the dominant cause.
Sir, is it possible that she has some sort of demyelination involved in the medial posterior column in the cervical region, unrelated to the B12 deficiency?
Both cuneus and galeries is maximally affected. Lower limb is maximally affected, but cuneus is also, upper limb is also incoordination is there.
My question is whether this could be predominant posterior column demyelination due to some other non-B12.
Yeah, right. Yeah, could be some other conditions like what is like think of a MOG or this thing condition, but no weakness possible. We can say no. Progression is there for the last 4 months.
Is more in favor of B12.
Okay.
Sir, we are getting, sir, just one thing, we are getting florid picture of upper motor neuron signs for pyramidal tract involvement in this case.
Yeah.
Am I right, sir? And very quick progression.
Yeah.
This is number 2. Number 3, she is a middle-aged lady, and also she has got some involvement of the posterior column with a sensory level up to the iliac crest.
Not some severe involvement. Here the maximum involvement.
Severe ataxia, which may be also sometimes due to the myelopathic components. Ataxia not only due to this posterior column, but gross myelopathy can also produce like that.
No. This is myelopathy, the ataxia due to the posterior column involvement or due to the cerebellar tract involvement. Ataxia.
Yeah, ataxia. And also she has got bladder problem.
Yeah. So that obviously myelopathy is there, no problem. What I'm trying to is that she's got a bipolar involvement and severe posterior column involvement, which is not able to feel the vibration at all. Right. So it's a severe posterior column ataxia.
Now, what is about this involvement of the posterior root ganglia?
But in that case, you get irreflexia, no?
Yeah. That should have been there. That should have been there. So something they were actually telling about vitamin B12 and other things. I was also thinking, but I do not know the final diagnosis.
Davis cervical myelopathy.
Pardon? First again.
High cervical compressive myelopathy.
Yeah, but the problem with the compressive myelopathy is that you won't get such a severe posterior column loss. This water power up to that extent. See, something which is affecting dominantly or exclusively with
Davis dorsalis.
Davis dorsalis is one condition which can produce a severe ataxia. But invariable tabes have got the root involvement to begin with. Actually, the involvement is second due to the radiculopathy. They get a reflexia.
And they get severe.
Will it cause this much rapid progression in tabes dorsalis? It's a chronic incidence.
It's a chronic, chronic. It's a chronic process.
Sir, I have got 2 points.
Yeah.
One is vibration level up to the iliac crest.
Yeah.
Another point
is also lost in the hand also.
But that is because of the preferential involvement of gracilis cuneatus, which is said to be more.
A cervical cord lesion can have predominant effect to the upper limb, can spare in between also, because it is not something like compressing like that. It can occur like that. Okay.
It is common with the B12.
Yeah, upper limb involved. See, B12 can have various presentation. It can predominantly the lower limb with the level below the midline, or it can be only to the upper limb. Like a patient where only upper limbs are affected, which was from sensory loss.
Sir, what about the HIV and VDRL in this patient, sir?
No, that I did not do, but I'll show you the investigations.
Yes, sir.
Okay, so this is the blood count.
Bladder involvement in B12 deficiency, sir.
Pardon? Yeah,
Bladder involvement in B12
that is
deficiency.
very well known in B12 deficiency. Between myelopathy and a bladder involvement, can early bladder involvement.
Cervical compressive myelopathy, cervical spondylotic myelopathy.
No, this is the problem. So it is not myelopathy. This is the point. With such a degree of severe posterior involvement, you get a little more weakness you expect in the upper limbs and lower limbs. And a questionable weakness only. Even the dorsiflex is also very minimal. The main problem, she is not able to, she does not know where her feet is. Upper limb power is normal, dorsal muscles are normal. So a disparity, you have to think of something non-compressive. And there's no level for any pain and temperature. Even with such severe posterior column, she has touch and pain is normal. That's the point against a compressive. Of course, we have to rule out that possibility. Agree with you. Okay, so this is the conduction. Say upper limb conduction is normal. Sensory conduction, only thing not elicitable is right supraperitoneal. All other sensory potentials are all normal. Telling you that there is no neuropathy in this patient. Patient's predominant involvement was posterior. Conduction normal. Upper abdomen normal. In profile SSA was positive. What else you need?
Homocysteine, sir.
Okay. MRI?
Yes.
MRI of the cervical cord. What did you see? You got hyperdensity in the posterior column. You can see long hyperdensity. Actually, a little more picture. This is hyperdensity in the posterior part of the spinal cord. In the posterolateral column. This is the hyperdensity in the cord. You can see the lateral cord as well as the posterior column.
So is this a heart sign, sir? Heart sign.
Heart appearance sign, sir.
Heart appearance. That is different. That is seen in the medulla. That is the unitus nucleus in the coronal cut. This is it's not like, it does not look like a heart.
V-shape.
Okay. So this is the brain normal. Vitamin B12 decreased.
141.
So this is a vitamin B12 deficiency.
Sir, so do you want to, do we have to do homocysteine once the B12 is low? Should we?
No, in this case, not required because already we have proved the point. We take this fitting with and we got a low B12 level, then we can go with that. You know what caused her problem? Probably she must have some gastric antibody which is causing his bile absorption. Moreover, she used to take this.
Fish tapeworm, sir.
Pardon? Not fish tapeworm. Antibody, gastric antibody, the antiparietal cell antibodies, which can, even though she's taking vitamin B12, non-vegetarian, it will not enter that is one of the commonest causes of B12 deficiency in our state, rather than the decreased dietary intake.
Intrinsic factor antibody.
Intrinsic factors.
Some OGD or colonoscopy in this case, sir?
No, in fact, this patient further investigation could not be done because I sent an antibody. But before that, I lost for the patient, I lost the patient for follow-up. She did not come back again. Because there is not much improvement, she must have gone for some other Ayurvedic treatment, I suppose.
This patient just one parenteral B12 supplement.
Parenteral B12, yeah, I should always keep parenteral. So whenever you get, unless if the antibody level is affected, always you have to give parenteral. If you go oral, nothing is going to improve.
What about the sublingual forms and all? Is it equal to
I do not know where across sublingual beetle. I don't know.
There are
Sir,
one
that
nasal
antibody
spray
was
is available.
positive.
Pardon?
Nasal
Nasal
Sir,
spray.
her antibody was positive.
No, that I could. Okay, I sent the antibody, but I didn't get the result. It should not come for follow-up.
Sir, sometimes this freshwater fish, if undercooked freshwater fish, if we eat, they can produce vitamin B12.
Okay.
So the nasal spray also improves the vitamin B12 level, sir. But not as much as the parenteral form, but compared to the oral form, it definitely improves.
Yeah, definitely. The gas antibody problem is solved with the oral forms only. Okay, I'll show this case. Umar need not answer because he was one of the person who called that. Not much of it got me. But the degree of attraction that they the limb goes into chorea. See the degree of ataxia. They must not know where the limb is. This is the problem I have said.
Just for completion sake.
The limb going to the theoretic movement here does not know where the limb is. So what is this condition?
Neuropathy.
Tropical attack neuropathy.
Pardon?
Tropical attack neuropathy.
Stop. See, you must have seen any number of diabetic neuropathy. Have you anyone seen with severe ataxia like that? They must have not loss of posterior column, the lower limb. You will not feel the vibe. They may be ataxic, but never to this extent. And however, diabetes, they will not produce an ataxia like this. So this is, pardon?
Ganglionopathy, sensory ganglion.
Ganglionopathy can produce severe ataxia. Severe ataxia. But this patient had an axonopathy, not myelopathy. Not CASP. The ganglionopathy can produce severe ataxia, depending upon which fibers are affected. So this is a condition which we only see in central area, tropical ataxia neuropathy. The patient might not have any weakness, reflex may be decreased. The sensory very minimal in this patient, very minimal sensory loss.
Sir, one doubt.
Yeah.
In Miller-Fisher syndrome, not related to this case, but in Miller-Fisher syndrome, the ataxia is sensory ataxia. So.
Yeah, it's a sensory ataxia, but not due to sensory loss. I'll explain that.
So Romberg will be positive.
Pardon?
Romberg sign will be positive.
Romberg sign can be positive.
What about JPS and vibration and all?
I'll tell you. In Miller-Fisher syndrome, the sensations are normal. In the sense that the perceptual sensation is normal. If we do the vibration sense, joint perception, they are usually normal. And if you know the conduction, sensory conduction, it can be normal. Okay. But what is happening is that the afferents on the muscle spindles, and the proprioceptive input on the muscle spindles, which are destined to go to the cerebellum for the control of coordination, is lost. So it is something like the afferent output to the class call of the spinocerebellar tract is affected. Because the peripheral nerve contains many fibers, those sensory fibers which are carried to your conscious perception of the sensation, like touch, pain, joint sense, vibration, all you are perceiving consciously. But there are other sensory input which are going to the cerebellum or your proprioceptive control of the coordination of the movements. But also you need an afferent input from the limbs, from the muscle spindles. So those fibers also carried through the peripheral nerves only. So peripheral neuropathy, if that affects first or predominantly, your perception will be normal. The large sensation fibers, maybe now say conduction also can be normal. but the patient will be ataxic. And that ataxia mimics a cerebellar ataxia. Just like anterior lobe of the cerebellum affected. They get incoordination of the lower limb and ataxia because sensory input, the proprioceptive input from the lower limb is not reaching the cerebellum. So that's the thing which is happening in the myelopathy syndrome.
Upper limbs will be spared. There won't be any finger loss.
In the case of myelopathy syndrome, upper limb also can be affected depending upon whether those muscle spindles from those muscles are affected. Upper limb is also ataxic in myelopathy syndrome, like an upper limb incoordination and a severe incoordination. Being a cerebellar ataxia.
Okay, thanks.
The clue to suspect myelopathy is that the reflex is lost. That tells you the lesion is in the peripheral nervous system. Why peripheral system? Because these are the fiber, the one-way fibers are the one which carries the upper input for the proprioceptive input inside. The same fibers are also going to the last column and going up. That is why in myelopathy you get ataxia and areflexia. Without any sensory loss. Sensory loss is not, they may be affected if other fibers are also affected. Just like we have various combination of myelopathy syndrome with GBS. Pure myelopathy syndrome at the end, and then pure GBS in between any sort of combination.
Okay, thank you, sir.
So this topic that is neuropathy is something mimicking a myelopathy syndrome. The effects is so out of proportion. That means peripheral neuropathy is affecting those fibers which are carrying fibers to the cerebellum. That's supposed to be it. Hence we have postulated in that article. Why these patients with severe ataxia.
So is the patient catheterized?
Pardon?
Is the patient catheterized? She is having urinary catheter.
Yeah, catheter is because she is not able to walk about. That is
that is the reason. Because the bladder should be spared in case.
Okay, shall I go to the next case?
The case sensations are normal, sir.
Pardon?
Sensations are normal in this patient.
Sensation in this particular lady, sensation is affected. Affected. But compared to that, what you commonly see in a diabetic neuropathy and all.
But how to differentiate it from CASP?
How to differentiate from CASP? In CASP, the reflexes will be retained. So reflex will be absent, snap will be retained.
Yes, sir.
In ganglion neuronopathy, they get absent reflexes and snap will be absent. Snap will be preserved, reflex will be absent.
So almost like
almost same. Ganglion neuronopathy and CASP behaves almost the same, except that electrophysiological snap will be preserved in CASP since the lesion is proximal to the ganglion, and the snap will be absent in ganglion neuronopathy.
Okay.
This girl has got an absent snaps.
Okay.
This story of a 70-year-old man. His complaint started as pain in the left shoulder 1 month prior to admission. This was followed by numbness of the left hand, which gradually ascended over the left forearm in 1 week's time. In another week's time, the numbness spread to the left side of the body. The next 10 days, patient noticed difficulty in walking in the form of unsteadiness of gait and clumsiness in the left foot. History of persistence in micturition for the last 5 days. So, 70-year-old man with complaints of pain in the left shoulder 1 month prior to admission. This is followed by numbness of the left hand, which ascended over the left forearm in 1 week's time. In another 1 week's time, numbness spread to the left side. For the next 10 days, patient noticed difficulty in walking, unsteadiness of gait, and clumsiness in the left foot. History of precipitation for the last 5 days. So it is something like a sensory problem, this patient.
We're going to need to pretend.
He is with eyes open, his hands doing wearing. On closing, it goes Even if it's upward, it goes somewhere else. It's for dystonic posturing. Dystonic posturing.
ശരി, കണ്ണ് തുറന്ന് കണ്ണ് തുറന്ന് കൈ ഇങ്ങനെ വെച്ചു. ഇനി കൈ നൂർത്ത് വെച്ചു.
Ask him, look at him.
നൂർത്ത് വെച്ചു. നൂർത്ത് പിടിച്ചു.
Power is normal.
മടക്കിക്ക്. അത് വിട്ടെ വിട്ടെ. ഇത് വിട്ടു. ഇത് പൊക്കിക്കാൻ മുകളിലോട്ട്. പിന്നെ പൊക്കിക്ക്. ഇത് പൊക്കിക്ക്.
Why? Because of the muscles in the hand.
ഇത് മുറുക്കി പിടിക്കുക. മുറുക്കി പിടിച്ച്. പിടിച്ചോ. വിട്ട്. വെള്ളകത്തി പിടിച്ച്. ഇങ്ങനെ കാണിക്കുക സ്പീഡിൽ.
Functions of the left hand.
കയ്യിലോട്ട് നോക്കി നീ. കയ്യിലോട്ട് നോക്കി.
You have to look at the hand and look at the hip. Looking at the hand.
കയ്യിലോട്ട് നോക്കി കാണാം.
Even then it goes into abnormal posturing and abnormal movement. You could not control the
കയ്യിൽ നോക്കിക്കൊണ്ടിരുന്നാ മതി.
Unlike a true dystonia, it is not patterned. The patterns are different.
കണ്ണ് നോക്കിക്കൊണ്ടേയിരിക്കെ. ഇനി കണ്ണും കടച്ചോ.
Closing the eyes, then it goes, the hand, where does it go? In the abdomen,
ബലം കൊടുക്കണ്ട. അവിടെ
the
വെച്ചിരുന്നാ
hand
മതി.
spontaneously levitates
ചുമ്മാ
upward.
വെച്ചോ.
It goes upward like that. It's on its own. It's not no. The press is absent in the upper limb. This is what I take. Left side it is absent.
ബലം കൊടുക്കണ്ട ചാ. അത്രയും വേണ്ട. പകുതി പകുതി. മടക്കി
The index of this bilateral. Plantar or subgoing. Subgoing on the left side.
ചെറുതായിട്ട് അല്ലേ? കൈ ഇങ്ങനെ എടുത്ത് കുഴപ്പമില്ല. ഇതറിയുന്നുണ്ടോ കിരീടം? ഇപ്പോഴോ? ഇല്ല.
You are able to feel the vibration.
മുകളിലോ താഴെയോ?
Not the joints.
എങ്ങനെ? താഴെയാണോ മുകളിലാണോ? കണ്ണടച്ചോ. ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴേ ഇത് അറിഞ്ഞൂടാ.
Yes, not no.
അറിഞ്ഞൂടല്ലോ.
So where is the lesion in this patient? On power, left upper limb, left deltoid, triceps muscle, gate 4+. Left finger extensors, plexus models, hand gate 3+. But there's always a problem in examining muscle power in the case of severe sensory loss. The patient does not know the position where the hand is, he will not be able to know whether he is exerting full power or not. So when you want to check the muscle power in a person in impaired posture column, ask him to look at the hand or look at the foot before you check the power. Otherwise, you get apparent weakness. Right upper limb is normal, lower limb grade 5, both lower limbs. Upper limb, left upper limb all absent. Right upper limb basis supinated plus, triceps 2+. Lower limb is bilaterally, left upgoing, right indefinite. Impaired vibration joints in both hands. Dystonic posturing and head posturing on the left hand and limitation. So where is the site of lesion?
Cervical cord on the left side, sir, involving the crossing five fibers as well as the fasciculus cuneatus and gracilis on the left side.
Very, very good. What is dystonic posturing?
That was because of the deafferentation, the useless hand of open.
So these things you should remember that some severe sensory attacks it may extend that can produce abnormal true dystonia. Even with eyes open, they can go into dystonic posturing and can go anywhere, can have levitation. Ballistic like movements in sensory deformation. So these things can occur.
But whether we can call it as a pseudo-ethetoid movement. Pseudo-ethetoid movements like posturing. There is some amount of dystonia, but when the peripheral system like posterior column is involved, we can have the pseudo-ethetoid movement.
Yeah, I'll tell you. The pseudo-ethetoid movement by definition is that with eyes open, the hand should not be moving. With eyes closed, it is moving. That is a pseudo-ethetoid movement. Here, the hand is remaining in abnormal posture even with eyes open. Not only a ethetoid movement, is also remaining in abnormal posture, dystonic posturing also. So what I'm trying to say, even dystonic posturing, true ethetotic posturing, ballistic movement, levitation can all occur with the sensory deformation. That's what I'm trying to say. The term pseudoethetosis is not actually correct. Definitely pseudoethetosis occurs only with eyes closed. But here occur even with eyes open. So what investigation need in this patient? As you all said, is MRI.
MRI cervical region.
MRI shows a tumor in the spinal cord, mainly the posterior part, and containing mainly to the left side. But is showing irregular enhancement. Is a tumor. Okay, so I brought these three cases to show you that last time there's some debate as whether the sensory ataxia can produce such a severe, also posterior can produce severe ataxia, can produce severe ataxia. Only two things you remember, that if it should not produce any nystagmus or ocular muscle involvement, nor in dysarthria. If these two are present, you can definitely say it is cerebellum. Otherwise, you just cannot differentiate it from a sensory ataxia. Cerebral ataxia cannot be sensory ataxia.
Sir, in this case, what could be the reason for the shoulder pain as well as the numbness on the left half of the upper limb and trunk?
It's got intermedullary lesion. No? Crossing fibers are affected, producing the pain irritation. Also, this pain, shoulder pain, also because of that crossing fiber involvement.
Okay, sir. Thank you.
So we are
Sir,
saying
how-
again that is the diagnosis, sir. We are mentioning
It's a tumor. It's affecting the posterior column, producing these abnormal movements.
So should we say pseudoethetosis or not?
Cathetosis, it's acetotic movement, correct.
So that I was telling.
Shall we stop here?
You can have a short case, sir.
Short case, okay. 21-year-old man, episodic tremulousness of the left foot for the last 2 months. These movements continues to last for about 1 hour and subside for about 1 hour. Previously present, but occurs for 1 hour, subsides again recurs. No other complaint, no numbers of weakness. Complaints of pain in the left calf bone. This is the involuntary movement. You just see what.
Control ಆಗುತ್ತದೆ ಇದು ಜಾಸ್ತಿ
My question was, okay. When did you notice only the tremulous?
Upper leg movements of the left foot.
2 months. Okay. So this tremulous movement is there for 2 months. 20 days it has become spread down to the other side, become focal being generalization. Now, for 2 months it has been there, no? That is continuously there episode.
Okay. What do you think the patient might be having? Semiologically, what could be that movement?
Okay, this one. Go on, keep. That's it.
Power is normal.
It's a painless moving toes, moving legs and painless toes, sir.
Okay. Something I've seen patients mimicking like that, painless toes and moving. But he's got a brisk reflexes in the left lower leg, compared to the right.
The C-sharp.
Yeah, it could be C-sharp indeed. Why not a tremor?
See that?
Look at the moment. Why can't be a tremor?
It is asynchronous. It is too clumsy for a tremor. It's asynchronous and it's non-stereotype.
Yeah, that's the thing. It's not rhythmic. It is not rhythmic or oscillatory. It is sometimes it's variable. Sometimes it is moving up, sometimes it's not moving. Something like a mini polymacron like.
For 2 months it has been done, no? That is continuously the episodic.
It's a regular type of a jerky movement, not like rhythmic. So it could well be a seizure also. It's a partial continuance. Because he has got a pyramidal sense on the left side. No weak left knee jerk is compared to the right. What do you want me to do?
EMG, sir.
MRI.
MRI where?
Brain.
Brain. Okay, this is the MRI brain. This is the lesion of the parasitic area there. Like it.
Okay.
Show that other film also.
Very classic case, sir.
Classic case. Good areas. Right? I can show.
Sir, was it epilepsy partially, sir?
Yeah, epilepsy partial scanning. There's some kind of granulomatous lesion there in the exactly in the put area. In the paracentral view. So this kind of a tremor-like, we can call cortical tremor or not, but we cannot tremor-like movement, but it's not rhythmic or irregular movement. Always think the possibility of a seizure-like phenomenon. That's the only thing about that is. But first look, it may not look like a seizure, not like a rhythmic, large, like a myoclonic movements that you get in this thing. I find tremor-like, but the irregularity and the variability should make us suspect that it's not a tremor. CS was normal. Look at the amount, the tubercular amount, and what it is. Whatever it is, such a lesion there.
Did it respond? Did it respond to any anti-epileptic drugs?
The movement responded to anti-epileptic drugs.
Was it treated with ATT, sir?
Pardon?
ATT? Was it given?
The patient and advise surgery to get the biopsy. Because we should not miss any other lesion, no? Like some other glioma or something. We don't. Okay. Shall we stop?
Yes, sir.
Okay, thank you.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you.
Good night.
Our best regards to you, sir. Our best regards.
Thank you. Thank you. Thank you. Thank you.
Sir, one doubt, sir.
Yeah, please.
Sir, how common is the spasticity without weakness to be kept in the corticospinal tract involvement?
Spasticity without weakness. That is common with non-compressive myelopathies because one important clue to differentiate compressive as non-compressive myelopathy is that the selectivity of tract involvement in non-compressive myelopathy. Like 2-3 points. Suppose you find a 5 or 10 year duration, you find a person with severe spasticity and no weakness, very unlikely for a compressive myelopathy. That means that to call pyramidal syndrome has got many things. But corticospinal fibers which are responsible for your movement. Also, that is fibers for your inhibitory fibers responsible for your brisk reflexes, fibers for action abdominal plus, and fibers for your upgoing plantar. There are also identified different fibers in the pyramidal system. In non-compressive myelopathy, it may affect only one type of group of fibers, sparing the others. And in motor neuron disease, it is abdominal top is spared. It is with the ongoing plantar. In myelopathy, invariably all components will be affected to to some other. You cannot have a only pure spasticity without weakness unless in the early. So you get a selective involvement. That selectivity always consider possibility of compressive myelopathy.
Madhu, what about superficial reflexes? Abdominal reflexes all will be retained, you know.
Yeah, then may also say I'll tell you, in certain compressive myelopathies like cervix moderate myelopathy or CVG anomaly, abdominal reflex can be preserved. So also cerebral palsy can be preserved. But what I'm trying to say is that if you find that kind of a pattern, think compressive myelopathy as a possibility. For example, in heterospastic, just an autoimmune disease, heterospastic therapy, and abdominal reflex may be totally spared. But you can have severe spasticity with no weakness, even 10 years, 15 years, severe spasticity, no weakness. So that pattern will be there. That's the thing you have to think. Only that means only some of the fibers in the pyramidal system is affected. That selectivity should always make you suspect that it's not the MCR.
Okay, sir. Thank
In
you.
motor neuron disease or progressive atherosclerosis, never you get bladder involvement. You get bladder involvement in all of the other conditions.
Okay.
Thanks, Madhu. Thanks, man. Thank you. Good night. Good night.
Good night.
Thank you, sir. Thank you, sir. Good night, sir. Good night, sir.
Good night.